It was just on with our many federal partners. Try not to abruptly leave them when they're being helpful. So I think I see Mr. Chair there.
Yes, I'm here. I'm
Great.
here, Nicole.
And do you want to go ahead and get us started then at 3 after, or do you want to wait a minute or so more? I'll leave it up to you.
No, it looks like we've got quite a number of people already logged on. So why don't we go ahead and get started, knowing full well that a few others may be wanting to get on also. I do need to get the agenda in front of me because I had the May agenda, not the August one. And let's see if I can get that.
Okay, sorry about that. I think Valerie just sent it out.
She did. She just sent it out. So now I'm trying to access it. Let's see if I can do that. And for whatever reason there. Okay, there, I'm ready. Okay, well, first of all, let me welcome everybody to today's meeting of the Medicaid Advisory Committee. I think this is the first one that we're having under our new schedule, the one we adopted at the last Medicaid Advisory meeting, for the purpose of getting our meetings more in line with what the Human Services Department's budget process is. And I think it is going to work significantly better now that we've got this approach. And I will turn it over now to Nicole Comeau, who is our Director of the Medical Assistance Division, just to review the meeting calls. So, Nicole.
Thanks, Mr. Chair. So good to be with you all again. I'm sorry that we are still remote. We had actually contemplated having this meeting in person again just a few weeks ago, but given the rapid increase in case count and the news that I'm sure you're all aware of, we decided that it was for the best to stay remote for the time being. So I think given our long time on these platforms, y'all are very familiar, but wanted to just remind folks to mute microphones, update your name and address so that we can track attendance. Committee members, certainly if you have questions, pop them in the chat as we're moving along, or at the end we'll open up for questions and answers as well. And presenters, we actually have a number of presenters that are not me today. Happy news for all of you. You don't have to hear me for 3 hours straight. And I would like to remind all of the presenters to ask for slides to be advanced as you're moving through your presentations. And lastly, this is being recorded. So if you have any concern, feel free to exit the meeting at this time. Okay, I think we're ready to move forward.
Yes, and Nicole, I'll let you take on item number 3 on the agenda, which is the introductions of committee members, although I believe we had adopted a different way to do roll call so that we don't take up a lot of meeting time doing it, correct?
Yes. So we had been going through the list of just the committee members and having you all say present, but I think just for sake of time, because we do have a very full set of presentations today, if committee members can please just write your name into the chat, we'll capture the chat log and capture attendance that way.
Okay, very good. Very good. So I know that everyone got the meeting agenda just a few minutes ago, but I've had an opportunity to take a look at it. And I think we do have a very full agenda today, and let's hope we can get through it in a reasonable time frame. I will ask the members of the Medicaid Advisory Committee if there are any changes that anyone wishes to make to the agenda. Hearing that there are none, then I will entertain a motion to approve the agenda.
This is Eileen Good. I'll make that motion to approve the agenda.
Thank you very much, Eileen. Do I have a second to Eileen's motion?
This is Troy. I'll second it.
Thank you, Troy. Thank you very much. Is there any discussion? Okay. Seeing that there is none, all those in favor of the motion to approve the agenda, please signify by saying aye.
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 If there are any abstentions, please say no. Okay, I hear none. Any abstentions? Okay, then the agenda has been approved. And we'll now go to item number 5 on the agenda, and that is the approval of the minutes of the previous meeting. And let me just compliment the staff at the Human Services Department. That is one of the most comprehensive and detailed minutes of a meeting that I've ever read, and it was, I think everything was hit right on. I know it was a lengthy set of minutes that we had, but I just want to commend staff for working so hard on them, because I do believe that they were a very accurate portrayal of the discussions that we had at the previous meeting. Does anyone have any corrections or edits to be made to the minutes of the meeting? Hearing none, I will entertain a motion to approve the minutes of the previous meeting.
This is Carol Luna Anderson, and I approve the minutes from the last meeting.
Thank you, Carol. I appreciate that motion. Do I have a second to Carol's motion?
This is Carolyn Montoya, and I second it.
Thank you, Carolyn. Okay, is there any discussion? Okay, seeing that there is none, all those in favor of the motion to approve the minutes of the previous meeting, please signify by saying aye.
Aye.
Anyone opposed, please say no. Okay. Any abstentions? Okay, hearing none, the minutes of the May 10th, 2021 meeting have been approved. And so we are now on item number 6, the agenda, Centennial Care Rewards presentation. And Nicole, I'll turn it over to you to introduce the presenter.
Thank you. So like I said previously, I am excited to have a number of different presenters today. I have been talking to you a lot in our last few meetings, but have some other folks who are willing to kind of jump in today and give you some updated information about programmatic efforts. There has been a lot of focus in the past now year and a half or so on the work that we've been doing around the pandemic. And of course that work continues, but while we were doing all of those, kind of critical pieces of work, we also kept doing the regular business of running Medicaid. And some of those things that have been going on have been pretty impressive efforts by the staff and the team. And so we wanted to update you all on some of those things that have been happening on the back end. There's certainly some overlap with pandemic response as that has kind of taken over our world here, of course, but there are some other pieces of work that are part of these efforts that I think will be really good for you all to hear about and be able to give us feedback about the direction of the Medicaid program outside of just our pandemic work. So first, we are going to get an update from Alexandra McDonald, Alex. She is the Finity Chief Client Officer, and they are our contractor and partner in running the Centennial Care Rewards program. So she's going to give you all a reminder about what that program is and what we've been up to in working with them. And I think you'll be pretty excited to see some of that data. I think, Alex, you'll have quite a few slides, but we moved some things around, so I think you have a good amount of time to make your way through. So I'm going to turn it over to you.
Great. Thank you, Nicole. Can you hear me okay?
We can.
Okay, wonderful. We'll check that box. Well, I just want to thank HSD and everyone for the opportunity to speak today about the Centennial Rewards program. I'll start with just a quick overview, followed by the latest results from Q2 of this year. And then every year we do a full cost savings analysis, and that was just completed for last year for 2020. So I do have those results to share as well. And I do have about 20 slides, but I think I can stick to my 15-minute slot. So here we go. Next slide, please. Actually, we can go to the next one. Thank you. So Finity has administered the Centennial Rewards Program since January of 2014 to provide a portable statewide engagement and quality improvement solution for New Mexico Medicaid beneficiaries in managed care. And the main goals of the program are, one, to generate cost savings by reducing overall medical expenses for program participants by getting them healthier and connecting them to care. Two is to really improve compliance to HEDIS and other state performance measures. And three is to really provide an effective communication channel to engage your Medicaid members in the state's top priorities, such as COVID vaccinations, flu shots, well-child immunizations, and more. And we work closely with HSD and the MCOs on those priorities. So the program language was actually included in the initial 1115 waiver, which was approved by CMS for federal match funding in 2014. And HSD had the MCOs conduct a joint procurement to select a single vendor. Finity was selected, and we've administered the program ever since. Government submitted by HSD and supported by MCO champions. We all meet quarterly as a work group. And HSD did include program language in the MCO contracts. So we actually contract directly with the MCOs. They pay the fees for the program to us, and HSD adjusts the rates accordingly. All right. So moving on to a little more background on the program, what it really does is bring member engagement and quality improvement combined into one health intelligence solution that provides a highly personalized member experience to really improve health and close gaps in care. So it features a closed loop multimedia engagement that we track and evolve with each member interaction. So what that means is we're going to know how members are responding best. So is it a text? Is it an email? Is it an outbound call? Is it print, web portal? We'll know that on a member by member basis, and then we can tailor the engagement accordingly to maximize outcomes. There's also personal life tracks on a variety of wellness and condition management topics, everything from maternal health to asthma, general preventive health, and everything in between. And we use machine learning to assign appropriate activities for each member based on HEDIS and wellness gaps in care, as well as social determinants of health. There's wellness challenges, such as the popular Step Up Walking Challenge to really engage members in their health. There's also healthy activities that are tied to reward points. So it's really easy math, members, $10 is equal to 100 points, but it's all gamified and it makes it more engaging. And we found that that's even more effective to increasing quality scores and really just motivating members to complete their gaps in care. And then there's integrated portals that will connect all the member data we gather, all the health, the SDOH data across participating MCOs. So on the next slide, you can see the reward activities that are included in this year's program. We do update those annually with MCO and HSD feedback. And they always align, of course, with the state's top priorities. So we have, adult dental checkups, adult PCP checkups, asthma medication adherence, bipolar medication adherence, child dental checkups. The COVID-19 vaccination was added this year, diabetes testing, flu shots, postpartum visit, prenatal visits, schizophrenia medication management, our Step Up 3-week and 9-week challenges, and well baby visits and immunizations with a bonus reward for series completion. Next slide, please. So up next, we have the multimedia campaigns that we're currently running this year, again, aligning with your top priorities and goals. So starting with the COVID vaccine campaign, this was a big push for this year. We sent texts and emails in Q1, starting in Q1, to really encourage unvaccinated members to get the vaccine and earn the reward. We relaunched that in June and temporarily increased the reward to $100 along with your statewide efforts to really get as many people as possible to complete the vaccine. We've also been doing quarterly childhood immunization, text and email campaigns to encourage parents to get their kids in for child visits on time and get immunized. We just launched a child dental campaign that was designed to get parents to get their kids in before the start of the school year for an annual dental checkup. We also have a campaign for adolescent immunizations. and general redemption. Since members are earning rewards for completing these healthy activities, we're letting them know when they've earned points and that they can go online or give us a call to redeem those points on essentials or other healthy items that they need most. And all those items are shipped right to their doors to eliminate any access issues. Okay. So up next, we do have a summary of the latest COVID-19 vaccine engagement efforts. So we started in Q1 with targeting elderly and high-risk members first. Then we moved on to include all members who are unvaccinated over 16. And then in June, we did that push for a 4-day period along with all of you to really engage members who are still unvaccinated over 12 to get the vaccine. We temporarily increased the reward to $100. We created a new video, a new portal call out, sent out over 77,000 texts in 4 days and 88,000 emails. And we're asking members to self-attest that they got the vaccine in order to give them the reward, because that's just the easiest way for us to get the data up until this point. We did have about 3,700 members self-attest during that 4-day period, but we know that doesn't represent the whole universe because not everybody's going to take the time to call in or go online to self-attest. So we have just received last week some updated data that will give us actual dates that members got the vaccine directly. And we're matching that against when these texts and emails went out so that we can really prove the effectiveness of our specific engagement efforts. And we'll be sharing that as soon as it's available. Okay, next slide, please. Now I'm going to go into the Q2 results and successes of the program. We do update results on a quarterly basis. So starting here, as you know, Medicaid eligibility rules throughout the pandemic were relaxed. So there's been a sharp increase in members eligible for the Centennial Rewards program, which has continued through Q2, reaching an all-time high of over 777,000 members eligible. Next slide, please. Since the beginning of the program, we have been conducting a satisfaction survey with the 4 questions you see here. Satisfaction remains high across the board through Q2 with over 27,000 members completing this survey in Q2 alone. Over 98% are satisfied with the program. Next slide, please. We also added a couple of new questions that just launched in Q1 of this year. And in Q2, we had over 25,000 members complete these new questions. You can see the results here. So are you satisfied with your care coordinator? 72% said yes, which is the vast majority because 26% said we don't have a care coordinator. 88% were satisfied with their doctor, 97% satisfied with their benefits through Centennial Care, which is great to see, and 97% satisfied with their health plan, which is also fabulous. And if we go to the next slide, you can see a breakdown by race, gender, and ethnicity. So the majority of members who completed the survey are Caucasian, followed by Native American. Over 83% are female. And in terms of ethnicity, about 58% are Hispanic compared to 41% non-Hispanic. Next slide, please. So despite, the impact of the pandemic, the Centennial Rewards Program cumulative participation has continued to rise year over year. And that's really a result of HSD's efforts to increase overall program engagement and public awareness around the importance of, keeping preventive visits, sticking to your medication through targeted multimedia campaigns. And because of this, and because the program has been so long running and has such a great reach across your Medicaid population, the cumulative participation reached a new high of over 73.7% so far in 2021. So on the next slide, here you can see the healthy activities that are completed quarter over quarter from pre-pandemic in 2019 all the way through Q2 of this year on a quarterly basis. We think this highlights well, how COVID-19 really depressed participation in doctor's visits throughout the pandemic compared to prior years across reward activities. Yet, as pandemic restrictions are starting to ease, we are seeing a rise in healthy activity completions compared to 2020. And in Q2 specifically, we continue the trend of members completing more healthy activities than the same time period in 2020. And we're getting closer to pre-pandemic rates. So we'll continue to track that. Next slide, please. And then, of course, when members are completing these healthy activities, they are earning rewards. So here we're looking at the reward dollars earned by quarter, again, from 2019 through today, Q2. And you can see that in Q2, over $1 million more was earned in rewards from healthy activity completed compared to the same time period last year. Still not quite at the same levels we saw in 2019, but we're getting there. So the trends are headed in the right direction. All right, and let's go ahead and move on, please. So one last slide. On the next slide, actually, we can see the top items that members are ordering with their reward points. We always track these. New additions from Q2 of this year are highlighted orange. So you can just see, there's been a trend in general throughout the pandemic of members redeeming for essentials, personal care items, and kitchen items, which has continued throughout Q2 2021. Next slide, please. So now I'll dive just a little bit deeper into the latest annual analysis for 2020, so last year. As I mentioned, we do run this annually. That comes out about every summer, so we're happy to send additional information, as desired, but I just have a couple of slides due to time today. So again, due to COVID, participation in preventive activities throughout last year were lower compared to prior years. There was a lot of public hesitation, as you know, in attending doctor's visits that posed barriers. And additionally, due to relaxed eligibility, there was just a sharp increase in members eligible for the program that at times outpaced their ability to participate. But despite these barriers, the 2020 cost savings, as you can see here, for participants in the program added over $46 million in reduced total medical spend compared to non-participants. So that got us to nearly $250 million in total savings since the beginning of the program. And when you compare that to 2019, we had over $58 million in savings compared to $46 million last year. We're really happy with that because we think it's a testament to just how hard we worked with HSD to keep getting members in as much as we could throughout a global pandemic to maintain those preventive visits. And I think that the savings could have been a lot lower without everyone's hard work and support. And the largest savings are coming from adult PCP visits, diabetes testing, baby visits, and HRA completions for years that was a reward activity. Next slide, please. So here you can see how the savings break down across reward activities for 2020. And again, you can see adult PCP, baby, diabetes testing, as well as asthma or refills and postpartum visits are actually the biggest savers when you line item these. And you can see how the data breaks down by the total population, those eligible, the participation rate by activity, the PMPM savings, and the total savings to get to that $46 million. And again, I'm happy to share more about the methodology that we have used year over year as a follow-up to this meeting. Next slide, please. So lastly, I just wanted to share a breakdown of portal access throughout 2020. We do have a Centennial Rewards portal that has a lot of traction. We also have a full call center, so members can participate either way. But we have very significant portal access. So throughout 2020, we had over 515,000 visits to the Centennial Rewards site. From just over 200,000 unique visitors. And this is really impressive since it primarily represents members who are 18 and over who can have a rewards account, which equates to well over 50% of your population who are visiting the site. And when they are visiting, they're spending a significant amount of time. So you can see on the left how it breaks down 22% from a computer, averaging over 18 minutes on the site and over 22 pages viewed. So they're going really deep. The majority of members are visiting from a smartphone, which we've seen for some time. So over 70% 100% from a smartphone, spending over 7 minutes on a site from a smartphone, clicking through almost 10 pages. So again, just really significant reach with this portal. And you should all be very proud of that. So thank you so much. I hope I stuck to 15 minutes. On behalf of Affinity, we are thrilled to be able to present to you today. Really appreciate the opportunity, and I'm happy to share more information as a follow-up. Thank you all.
Thank you, Alexandra. That was quite a bit of information there. Do any of the Medicaid Advisory Committee members have any questions of Alexandra before we proceed? Then why don't we go forward then, Nicole?
Thanks, Alex. I would just give a couple notes. I think it's not often that New Mexico gets to be kind of first in line on things or number one in the country. And this rewards program is really an innovation in the delivery of Medicaid. And really, as you can tell, is helping to drive some positive behaviors. And so something that the team has been working on and proceeds are coming on in this administration, and just something I think everybody should be pretty proud of as a state and a program. I will say that you saw the additional, somebody's not muted. You saw the additional reward that we added for COVID vaccine administration for a period of time in the big push before July, given what we are seeing happen now, and given that Medicaid rates with the data that we have vaccination rates appear to be lower than the overall state rates. We are considering again another push there and adding more to that reward to try to further incentivize our population here. So just a great way to do that, and really helps folks, and then gives them access to purchase, again, things that are health related with those reward dollars. Okay, I think now we are moving forward to our partners at Blue Cross Blue Shield, and I think that everybody who is presenting is in. Sorry for the struggle there. But again, we've done a lot of presenting from the Human Services Department, but we are, of course, very close partners with the managed care organizations, as we are with all of you, and wanted to give the MCOs an opportunity to talk about some of the work that they're doing outside of what you all may think of their kind of traditional efforts with our members. And so today Blue Cross is going to present, and then at the meetings to follow, we'll have slots for both Western Sky and Presbyterian as well. So Sharon, I think I'm turning it over to you.
Thank you, Nicole. I appreciate the opportunity that you presented for us to be able to present the workforce expansion pilot program that Blue Cross has with New Mexico State. So we can go ahead and move forward with the slide. Next slide, please. Go ahead and go to the next slide. Thank you. So Blue Cross Blue Shield recognized that we need, that there's a shortage of the workforce in New Mexico, especially after the Medicaid expansion in New Mexico. And so what we did was we developed a pilot program with New Mexico State University, and we granted them, we gave them a gift of $500,000. And what I learned through this partnership is that there was quite a few social workers who were, or students who were waiting to get into the social work program. And likewise, there was also nurses that were waiting to get into the program, but because New Mexico State didn't necessarily have all the workforce that they needed, we needed some additional professors of practice to enable them to allow additional students into the program. We granted them we gave them a $300,000 award, which would enable them to appoint a professor of practice for a 3-year appointment period for the School of Nursing. And in addition to what we also did was we gave them $5,000 scholarships to award to undergraduate nursing students. and also $25,000 scholarships for social workers. So that or for students who wanted to go into this social work program. Next slide. And really the goal of this program was to ensure that we could increase access for these programs. And Dr. Doig, who is my partner here today, she's the director of the School of Nursing at New Mexico State, will go into more detail as to what additional goals of the program and what we're doing. But we really wanted to ensure that post-graduation we had a workforce ready, folks that were ready to move into the field. We also wanted to increase the number of those people who graduated, and specifically we wanted those folks to understand the Medicaid managed care program. A lot of the time what we're seeing is that folks graduate and they don't really understand how services are funded, et cetera. So we've partnered, and I'd like to turn this over to Dr. Doig, who is the director at New Mexico State University, and she can complete the rest of the presentation. Dr. Doig?
Great. Well, yeah, I'm here. Great. Thank you, Sharon. And thank you everyone for giving us some time to present on this partnership today. This was truly a transformational gift to NMSU and to the School of Nursing. We really had not been the beneficiaries of this kind of generosity before it. And these days, support from our healthcare organizations for nursing programs, social work programs, and other healthcare workforce programs are really critical because our state funding and other sources of funding keep decreasing, as I'm sure you're aware. So yes, these goals were really critical. We have a group of, we have students who come from underserved backgrounds. We have students we have about 50% first generation college students who really struggle to pay for their nursing and social work education. And so the scholarships were really critical here. And then I'll talk more about the professor of practice in a little bit. Next slide, please. So just a little bit about the New Mexico State University School of Nursing. So we are a nationally accredited program. We have a Bachelor of Science degree in nursing program, which is our undergraduate four-year program. We have a graduate programs, MSN program in nursing leadership and administration, and then our DNP program and postgraduate certificates focus on training family nurse practitioners and psychiatric mental health nurse practitioners. We really have designed our graduate programs to meet the needs of the state and especially of the community here in southern New Mexico. And so we've really focused on primary care community-based nurse practitioner programs. As all nursing programs do, of course, we have a combination of classroom instruction, skills practice, simulation, and then practice experience in the hospitals and community settings. And then, underlying all of our curriculum is an understanding of our diverse communities in New Mexico, concepts such as health disparities. We teach cultural competence. We really do help to prepare both our undergraduates and our nurse practitioner students to practice and contribute to the healthcare needs in New Mexico. Next slide, please. As I was saying, these scholarships for nursing and also for social work were really truly incredible. These are some of the largest scholarships that we're able to offer at NMSU. What we did was ask students to sign a one-year commitment to work in New Mexico after graduation. The vast majority of these scholarship recipients were New Mexico natives. Of the 20 that were awarded in the 2020-21 academic year, that should say 8 graduated in May. So we have 8 who are taking their board exams right now, and then the other 12 will graduate in December of this year. What we are planning to do in collaboration with New Mexico Blue Cross Blue Shield is to track these students and track where they're employed, what type of work they're doing, of course, what kind of healthcare setting they're in, and really try to see what the outcomes are of this program. I chose this quote from one of our students, one of our scholarship recipients, one of our outstanding students who's going to graduate in December. This is Venetia Sam, and she is actually a second-degree student. We have an accelerated program we call the Roadrunner program that tries to recruit our best and brightest from the community who maybe have other degrees and other careers into nursing. And Venetia talked in her letter, in her thank you letter to the organization. She's talked about how her parents were supportive, but they also support their grandchildren and other siblings, and just didn't have the finances to send her to school. It didn't bother her one bit. She did what she needed to do, and to work her way through school. And she was so grateful for this scholarship. It really made a true difference in helping her get to graduation this December. And so with that, she expressed her deep gratitude. Next slide, please. We had a very similar program in the School of Social Work. We awarded 20 scholarships, and again, graduating either had graduated in May 2021 or will graduate next year, and they will track the same kind of data. They track the data a little sooner just because we have to track a little further out because our licensing exam sometimes takes students a little longer to get through. Oh, and one thing I wanted to point out here was the School of Social Work has worked with Blue Cross Blue Shield of New Mexico to organize some internships within the organization. And so we're really excited about that piece of the partnership as well, too. Next slide. So Sharon talked a little bit about a professor of practice, and again, this is a fairly novel position at NMSU, but we're excited to be the pioneers. The idea of a professor of practice at a university is to take, in the case of nursing, an experienced clinician who can really bring their field experience, in this case their nursing experience, into the classroom, and really has that deep connection to the community. Our first professor of practice is Elizabeth Kuchler, who is a family nurse practitioner, and she has worked in the community for over 30 years, and she is on the faculty, and she teaches in the family nurse practitioner program. She also has a part of her appointment really focused on outreach, on identifying new sites for nurse practitioner, family nurse practitioner, and psych mental health nurse practitioner students, especially in the areas of opioid and other substance use disorders, which is a big focus of our 2 nurse practitioner programs. And so she has been our inaugural professor of practice and will be in this appointment for the next 2 years. So she just completed her first year. Next slide. And another big piece of this program, as Sharon was saying, was to make sure that our graduates, especially our nurse practitioner students, are graduating with a knowledge of Medicaid managed care. That was very critical and a core part of the partnership. And so what we did was we organized a seminar as a part of our nurse practitioner kind of hands-on training, and with Elvia, yes, Provincia, in the program, who came and did a presentation to almost 40 of our nurse practitioner students across both of our programs. And the students, this was something that our faculty are, of course, aware of it from the provider standpoint, but having somebody come in to really talk about it from the Medicaid managed care point of view was really critical. The presentation got rave reviews. The students learned a lot specifically about Centennial Care of New Mexico, but really kind of understanding that purpose of care coordination and care management. And so we will continue to do that particular presentation on an annual basis to all of our nurse practitioner students. And then we are planning a Medicaid behavioral health presentation in the fall semester, focus on that area. And then we're looking at developing another presentation or workshop on medically fragile populations as well too. Next slide. And I think last slide. Just to give you a sense of where we're going in the future, a few things going on in the School of Nursing. We are working to develop and launch a nurse anesthesiology program. And that is because there is a critical need now, and we're projecting in the future of anesthesia providers in New Mexico. I'm sure you're all aware, as you know, no anesthesia, no surgeries, and there's a number of medical procedures that also require medical procedures that also require anesthesia. So this has been identified by healthcare facilities and other organizations throughout the state, and by the National Organization of Nurses, the New Mexico Association of Nurse Anesthetists, as a really critical need. And we're in a position to develop and launch this program. We're hoping to get it accredited by April 2022, with a start date for students in January 2023, if all goes well. We have grown considerably in the past couple years. Our BSN enrollment growth program has grown by 35%. We currently have over 400 students in the program. And our nurse practitioner programs, their enrollment has doubled over the past couple years. So at New Mexico State, we really are trying to grow in order to be able, for a couple reasons, of course.
Did we?
I think we lost.
I'm sorry, my hand gesture hit the mute.
Okay.
My apologies.
Okay.
Really making sure that individuals who are qualified to become a nurse and want to become a nurse have an opportunity to become a nurse, and then nurses who are interested in becoming a family nurse practitioner, a psychiatric mental health nurse practitioner, both areas of critical need in this state, that they have this opportunity. Our NP programs are offered via distance education, so nurses who live in rural communities can stay in those communities, do their clinicals in those communities, and do all of their coursework in an online environment. And we've been doing that for over 6 years at this point. And then lastly, we are working on a proposal to renovate our Skills and Simulation Center. It's about 20 years old, and it deserves a big upgrade. And so we're working on the plans with a capital outlay funding from the governor for this year to do some planning, and then we'll be looking at funding for the project in the future. So I think that is it.
Thank you, Dr. Doig. I appreciate it.
You're
Thank
very
you.
welcome.
And are there any questions from any of the members of the Medicaid Advisory Committee?
This is Carolyn Montoya. I just wanted to congratulate Dr. Doig on a great presentation and really highlighting the need for more nurses within New Mexico. Right now, New Mexico is facing a shortage of about 6,000. And so they have had a very strong program and growth very similar to what we do. And especially nice is the partnership that they have with Blue Cross Blue Shield. We attempt to do the same thing through HRSA grants with advanced nursing education workforce grants that help to keep nurses in rural areas, particularly our nurse practitioners. So kudos, great information, and we love working with NMSU as a partner.
Well, thank you, Dr. Montoya. We appreciate your partnership as well, too.
Yes, thank you for those remarks, Carolyn. Okay, seeing that there are no other questions, want to thank you very much again, Dr. Doig, and I will turn it over now to Nicole, because I think our next.
Yeah, thank you. And thank you both to Blue Cross and Dr. Doig for presenting, and Carolyn for your comments. I think many of you are aware that we have been talking since 2019, since we came on board here, and I know you all long before that, about the need and responsibility of the Medicaid program to help with the development and sustaining of the safety net here in New Mexico and the provider infrastructure. To that end, we've been working on some efforts around graduate medical education that I think many of you are familiar with. And then just a couple of weeks ago, we had the first primary care council meeting, which was established in this past legislative session, and is comprised of a really great group of folks, clinicians and other stakeholders from across the state. And I think a number of you are participating, but I think all of these efforts kind of go hand in hand. And I'm just really appreciative of the presentation today and the continued effort to try to bring providers in and grow them up here in New Mexico and keep them here. So thank you for that and for the time, and thank you to Blue Cross for the innovation there and support, and look forward to hearing from the other MCOs about other efforts in our meetings to come. So the next part of the presentation, fairly brief, but we wanted to make sure was clear for you all on what's been going on with our managed care organizations. And so I'm going to turn over to my Deputy Director, Megan Pfeffer.
Good afternoon, everyone. If we could move to the next slide, that'd be great, thanks. So our current contracts started January 1st, 2019 with the MCOs. Originally were set to expire December 31st, 2022. We do have an option to extend annually up to 4 years beyond that. We are taking one of those options for an extension through the end of December 2023, with the new contracts starting January 1st, 2024. We will start doing the procurement pretty soon here. The scope of work development will begin this winter. And then we hope to have the procurement finalized by late 2022, with readiness sometime during 2023, with the contracts effective January 1st, 2024. With this extension, we are going to be adding a few more items to the MCO's contracts. In particular, we're going to take a look at some performance measures targeting the EBSTAT for children. We're also going to be working with the MCOs to submit a plan offering on BUL&M. We'd like to revise value-based purchasing programs to develop some sort of incentive payment directly paid to the frontline staff, such as nurses, nurse practitioners, doctors, PAs, MAs, etc. And then the last part, we are looking at increasing the minimum medical cost ratio. So all of these items are going to be put in a letter of direction, actually, fairly soon, and sent out so the MCOs can start working on those. And that's really all the update I have. Thank you.
I'd like to ask a question, Megan, if at all possible. What precisely is the impact of increasing the minimum medical cost ratio?
The impact to the MCOs?
Yes.
So currently, the MCOs are directed in the contract to not spend, no less than 86% of the Medicaid line of business net capitation revenue on the direct medical expenses, and that's on an annual basis. And so we're looking at increasing it to 88.
Okay. Okay, I understand. Thank you very much.
Sure. So
Okay,
next slide.
Nicole, we're at item number 9 on the agenda, HSD dashboards.
Yes, thanks Megan for the update. And I know that there had been some stakeholder folks who had attended meetings that were asking questions about the status of our procurement. So we just wanted to provide you all with that update. So, okay, now wanted to share some information. We can go ahead and advance the slides. Thank you. So in the materials that went out, you should have the most recent set of dashboards for the program. If they haven't gone out already, I'm sure they will any moment, and I apologize for the delay. That's actually very much on me and not the team. I was editing things at the last minute. We have included for you all the dashboards that run through December 2020. I'm sorry that it is not the most recent set from the first quarter of this year. but we are working on some data issues with a couple of the MCOs, quite frankly, and have not been able to get those all the way resolved in a way that we're happy with the data and ready to share. So we will get them resolved and hope to do so here within the next couple of weeks, and then we will just send out the more current set of dashboards to this body. And if you have any questions, of course, feel free to reach out. I think the best way to get answers on that would be to send them to myself and to Valerie, and we will work through getting responses out to you. But I did want to call out a couple of things in the dashboards that you all have. This is obviously far too small to see. I was just including it as a visual representation, but you do have each of the dashboards in your email. And so, as I stated, these are a comparison from January 2019 through, January 2020. And then we have the next comparison from 2020. I'm sorry, I'm mixing up the dates because we're behind here. So the current months that we have for you, it's 12 months from January 1st, 2020 through December 31st, 2020. Apologies. Okay, we're clear. So basically all of 2020 are pandemic, primarily pandemic year. And the things that I wanted to just highlight for you all as you take a look at the dashboards themselves are that, of course, you can see the very significant increase in the managed care and overall Medicaid enrollment. In managed care, in aggregate, there's an increase of 6% from the previous to the current period. That increase is comprised primarily of a 6% increase in physical health enrollment, a 2% increase in aggregate long-term services and support enrollment, and a 7% increase in the other adult group. So similar to previous dashboards, the enrollment graph does show that dip for the most recent month at the end, and that's of course due to retroactivity and not likely due to an actual dip in the growth of the population because, as you all know, we are still currently within the maintenance of effort requirement, and so we are not able to disenroll anyone, and again, we are seeing somewhat of a slow in the growth of the population, but nothing that is actually an actual decline. So I see a note in the chat that folks don't have the dashboards yet. I'll just pause and see. Valerie, were you guys able to get those out?
Nicole, I'll jump in here. Alicia did attach them to your meeting invite. So if you open your invite, they
thank you.
are attached.
Thanks, Lisa. So Dale, hopefully folks heard that they're actually in the meeting invite, not in your email. Apologies. Okay. I also wanted to just call out the MCO per capita medical costs. So in aggregate, the medical costs have increased by 7% from the previous to current period. This is driven by a 6% increase in pharmacy services and an 8% increase in non-pharmacy services. When you are reviewing those per capita medical costs by program, you can see that actually behavioral health had the largest per member per month increase at 21%. And that was driven primarily by outpatient, the behavioral health outpatient fee increase, which was effective in October of 2019. So again, all of these program implementations where rates were adjusted and increased, play out in the later months, and so that's what you can see driving some of these increases now. Those rates went up, and utilization has continued to increase in behavioral health, and you can see those costs driving our overall spending on the MCO side. Additionally, long-term services and supports had a 15% increase. That was primarily driven by the PCO, the personal care services increase in July of 2019 and in January of 2020. And then finally, the other adult group on the physical health side had an increase of 9%. And I think those are our primary drivers there when you actually get to dig into the dashboards. You'll see some of this also reflected when Elisa gets into the budget, but we did want to just call them out in reference to those that we know folks have been looking for. There's some interesting numbers also in the dashboard that I asked Mercer for some additional information about. So if folks have any follow-up questions, feel free to reach out. One of those, anything that's like something more than a 50% increase or decrease kind of sets me off a little bit there and very concerned about what's happening. Often it's in the much smaller lines, and when that's the case, there's volatility that can cause that kind of a shift. But in some of the more sizable lines, one that I did want to just note, well, there's two. The LTSS NIFLOC Medicaid only population had a 65% increase in HCBS services. And I asked Mercer what was driving that, and it appears that the primary driver of that increase is actually in respite services. Expenses actually doubled from 4.1 million to 8.6 million, and unique users increased by approximately 50% when comparing calendar year 2020 to 2019. And I think that is something that you would really expect to see in light of the pandemic, right? There was a push for folks to get people out of those congregate settings and to take care of them at home. But of course, families were still having to work, and some of them having to go into work. And so certainly in need of those respite services. So an interesting number I thought to call out to you all as you're looking at those. There is a number, and Dale, you'll have interest in this one potentially. There's a 54% decrease in brand prescription expenditures. And there's not an obvious driver, so we're going to dig into that a little bit further. But I did notice that one, and we'll keep tracking on what's happening there. So just a few of the key numbers as you all dig through the dashboards. If you have other questions, please feel free to let us know. And if there's something that you want us to cover on those dashboards in the future, if you can note that in the chat, it'd be really helpful, and we will make sure to be able to speak to whatever questions you may have. They are lengthy and have a lot of information, so thought we would just call out a couple of pertinent pieces, but don't want to miss things if folks have questions about anything in particular. All right, let's go ahead and move forward.
Let's move forward, Nicole.
It's going backwards. Okay, there we go. All right, and so Elisa is going to start us off with the budget projection now, and I will jump in and out with her as she walks us through. Elisa?
Good afternoon, everybody. All right, here we go, getting into the budget projections. So as you know, we produce a quarterly budget projection. So what you're gonna see is the data projection with, the quarterly budget projection with data through June of 2021. All right, next slide, please. Okay, so we're going to talk about some federal coronavirus relief. We're going to get into the enrollment projection. This will be the last time you see the fiscal year 2020 budget projection. We produce it for 2 years, and then we close it out, and then the accountants take over the tracking of that projection. So then you're going to see the FY21 lag model. We have the FY22 trend model. You will not see the FY23 trend model. We are working on it right now as part of our budget request for the legislative session that's coming up in January, and we're going to submit this on September 1st. So the next time we meet, you will have a preview of our FY23 projection. And then we'll discuss some of the risk factors that have been built into the budget. Next slide. Okay, next slide. All right, so as you all know, we do have a maintenance of effort requirement as part of receiving the 6.2 additional FMAP bump that we've been receiving since January 1st of 2020 and through the end of the PHE. So the PHE was extended one more time. So we do expect to receive the 6.2 through the end of December. And right now we have about 140,000 individuals on as a result of this maintenance of effort requirement. And we're going to talk about how this is impacting the budget and the impact once these people are rolled off. Next slide, please. Okay, as I mentioned, on July 20th, the PHE was renewed again and through October 21st, 2021. So since that date falls in the last quarter of this fiscal year, of this calendar year, so the last quarter is October, November, December, we receive the 6.2 for the entire quarter. It is possible that the PHE will be extended again, but as of now, it's only been extended through October. Okay, next slide. All right, so what you see here is a change in the FMAP from federal fiscal year 2019 through federal fiscal year 2022. As I mentioned, we did receive the 6.2% additional FMAP, and it's built into the projection through December 2021. So it's built in for 6 months of this current state fiscal year that we're in. So we are currently in state fiscal year 2022. So we have the 6.2 built in for 6 months, and then the 6.2 will expire for the second 6 months. Okay, and then right here, we've also included on the last line, you've all heard about the home and community-based service 10% FMAP enhancement that we anticipate to receive starting on April 1st of this year through March of 31st of next year. We do have 3 years to use this funding, but the 10% we only receive in this first year. And I just wanted to comment that to receive this 10%, states must implement or expand one or more activities to enhance home and community-based services. So it doesn't offset our general fund need. Okay, and we'll be, I think you've all heard about the spending plan, and it is posted on our website. Okay, next slide. All right, so with the current FMAP in our state, the blended FMAP right now with the 6.2 is 80.58%, which means the state has to come up with 19.42%. So it's the blended rate for the state fiscal year based on the federal FMAP percentages. And so what happens is this provides the state a return of $4.15 in federal dollars for every $1 that the states invests in Medicaid for fiscal year 22. And just a reminder, this $4.15 does include the 6.2% FMAP enhancement. If we didn't have that 6.2, then we would receive $3.64, slightly lower. Okay, next slide. Okay, so yeah, go ahead, Nicole.
Sure. So we wanted to run through just a couple of things with you all regarding the American Rescue Plan Act and potential Medicaid impacts. So there are a number of provisions, obviously, in that statute, and the ones listed here are just the provisions that impact Medicaid. We already talked with you all about Elisa just mentioned the additional 10% FMAP for home and community-based service improvement activities. Additionally, I think we've spoken with you all about the 100% federal match for COVID-19 vaccine administration. We are preparing now for work around a grant related to mobile crisis services that will help us in I guess, initial activities, I should say, as we prepare to draw down this additional 85, well, it's not additional, but it will be an 85% match rate for those community-based mobile crisis services beginning April of 22 and running through March of 25. The other that we've talked about with you all is the extension of postpartum coverage from 60 days to 12 months. We are proposing that expansion to the legislature and have put that into our 23 budget. Only 1/4 of it would be relevant in this 22 budget, and Elisa will talk to you about that more as we get through the presentation here. There are a number of other smaller items that you can see listed in the table here, but those are the ones that we wanted to make sure you all were aware we're currently underway, and certainly, of course, we're working on the others, but those at the top are the larger financial impacts. And Elisa, I'll let you take back over.
Thanks, Nicole. Okay, next slide, please. Right, so now we get into the portion of the budget projection where we're going to go over 20, 21, and 22. For this projection, there's not big changes. Oh, never mind. I'll get to that. Okay, so overall, the FY20 expenditure this quarter was revised down $3.8 million from the previous projection for a total expenditure projection of $6.5 billion. And for FY22, the second column there, we did revise the projection up by $6.5 million from the previous projection for a total expenditure of about $7.3 billion. And in FY22, the expenditure projection this quarter was revised up by $55.2 million from the previous projection for a total of almost $7.6 billion. Most of this increase is due to extending the MOE population roll-off for 6 months. So previously we had built in that we would be able to roll off the MOE population for 3 months, and now we've extended it to 6 months. And we'll get into a little more detail about that. So let's see, next slide, please. Okay, so here are the revenue projections. In FY 2020, the revenue projection was revised up about just under $1 million, about $600,000 from the previous projection, for a total projected surplus of $46.9 million. And as you all know, most of this surplus is due to the 6.2% FMAP that we've been receiving. Okay. And for FY21, the revenue projection was revised down $1.2 million for a total projected surplus of $48.6 million. In FY22, the revenue projection was revised down $12.6 million. So now we have a greater shortfall, and our shortfall is now projected at $87.6 million. And most of this is due to extending the MOE population roll-off for 6 months rather than 3 months, excuse me. And a couple of other changes, such as downward revisions to the tobacco settlement fund revenue that we received as well. Okay, next slide. Okay. Now we'll get into the Medicaid enrollment projection. Next slide. Okay, so by June of 2020, we had served almost 937,000 beneficiaries. We project that enrollment to increase to over 957,000 by December 2021. And then we're going to decline to about 899,000 by March, and then further decline by June of 2022 as we roll off those MOE population. And the reason we're rolling them off is because they're no longer income eligible clients. Okay. And then 82% of our beneficiaries are enrolled in managed care. So that's the largest driver of our costs is the managed care costs. 45% of New Mexicans are now enrolled in our program, while 58% of all New Mexico children are enrolled in Medicaid. And we cover 71% of all New Mexico births. Next slide. Okay, the enrollment projection does continue to take into consideration, of course, the public health emergency, the MOE requirements, and the current economic outlook. Next slide. Okay, the next 3 slides will present the detailed enrollment projection, which includes the full benefit and partial benefit projection. Next slide, please. So in 2020, you can see, I want to draw your attention to the 2 far right columns. So on the far right, we have the growth from before the PHE. So for Medicaid purposes, we started seeing the impact on our enrollment in March of 2020. So for this purpose, the pre-PHE is February 2020. So all those numbers on the right are how much has the enrollment population grown since before the public health emergency began. Okay, next slide. Okay, so for 2021, in the final month of fiscal year 2021, June 2021, our growth is now at 12.2% from before the PHE. And you can see the month-over-month growth it started off growing very quickly. It was like 8,000 a month, and now we're starting to see a little more stabilization in our numbers, but we're still growing month over month. Okay, next slide. So in fiscal year 22, by December of 2021, before the 6.2 expires, and we begin our MOE roll-off, our enrollment will have grown 14.6%. And so after that, you'll see those negative numbers in the second to right column is when we start the roll-off. Now, I did mention that our roll-off is planned over 6 months. So the way we built our enrollment projection is we actually had the enrollment roll-off over 3 months. And then we have an add factor in the budget to account for the cost of taking 6 months to roll off. So when you look at the enrollment, you'll only see the 3-month plan, but the cost is built into the projection of the 6-month roll off. Okay, next slide. All right, so now the next 3 slides are very similar, but they're the managed care enrollment only. So the ones you just saw were the fee-for-service and managed care, the partial benefits and the full benefit. This is managed care only. Now we've been asked, why did we produce 2 separate projections? Well, most of our costs are in managed care. Therefore, we track both enrollments very closely, but the managed care projection really is our cost driver. So you will see similar patterns here. For fiscal year 2020, February is before the PHE began, so you'll see the far right column. We've included a growth factor for growth in our enrollment from before the PHE. Next slide, please. So by June of 2021, which is this data projection, and I just noticed that I didn't do the red columns should be around what's the current projection, and it is through June of 2021. So our growth has reached about 14.7%. And I don't know if you remember what I said, but for the total enrollment projection, it was 12.2. So you can see our managed care enrollment has grown faster than the overall population. Next slide. So by the time the PHE ends on December of 2020, we do project our managed care enrollment to have grown by 16.9% before we begin that MOE roll-off. Okay, next slide. So this is just a graphical representation of those numbers you saw, our total enrollment projection. And as you can see, we were before the start of the PHE, which is the green bar, we were fairly flat. And then the PHE began and our enrollment started growing again. And it continues to grow until the MOE expiration. Now, if we come back next time and the PHE has been extended another quarter, another 90 days, then you will see that bar extend another 3 months, 3 months. Every time the PHE is extended, we have to maintain that MOE population on Medicaid. And so you will see this projection change. But for now, we've built in the PHE ending after December 31st. Okay, next projection. Next slide. Okay, FY22. So as I mentioned, not many changes in 20 or 21 to talk about. Pretty small changes in comparison to the large size of the budget. So we're only going to discuss the FY22 changes. Next slide. Okay, most of the changes were in managed care. So the Centennial Care Physical Health Program at the top you see, was revised down by 15.7 million from the previous projection. This reflects a decrease of about 5 million in member month changes, with the majority of it, about 10 million, from changes in the PMPM. So this one includes recent rate changes, revisions to the Centennial home visit. We added 2 providers, revisions to the nursing facility HCWIS. The nursing included a NIF MBI directed payments, and revision to the health home program. So some of these were upward and downward revisions that were built in. Okay, for the Centennial Care Long-Term Services and Supports Program, we did revise it up by $9 million from the previous projection, and it's all due to these PMPM changes. So we did have some rate changes from the same impacts on the physical health. So there's just some shifting that went on in which line those rate changes were reflected in between physical health and LTSS. So for the Medicaid expansion physical health program, as you can see, it was also revised down about $5.5 million. Most of that was due to PMPM changes. Okay, the other line you're going to see at the bottom of this chart is the COVID-19 related expenditures. So that's a change of $52.9 million. So 50 million of that, or $8 million general fund, is due to the MOE being roll off for another 3 months. So that's where we've built in that additional 3-month roll off through of June of 2022. The other expense that is built into this line is 2.4 million from extending the postpartum coverage for a full 12 months that Nicole had mentioned previously. So this 12 months starts April 1st, 2022. So the impact is not large in fiscal year 22 because it's only impacting 1 quarter, and so it's not impacting a lot of our beneficiaries. The largest impact will be built into the fiscal year 23 budget projection request that we will produce, and that will impact a full year. So the cost will be much larger in 2023. Right below that is the Healthcare Affordability Fund tax from the session, House Bill 317. So we built in a cost of 15.4 million. This tax starts on January 1st, 2022. So this impact you see here is only for half a year. And again, in fiscal year 23, we will build in a full year impact. Next slide, please. Okay, so in addition to the changes in expenditures that we were discussing, here's changes in the revenue. So we did revise it down to the revenue estimate for the tobacco line was revised down about $2 million. So in total, our shortfall is now $87.6 million, or a $12.6 million change from the previous estimate. Just again, mostly due to those changes in the MOE, and some of it was the tobacco. Okay, next slide. Okay, now we're going to get into the risk factors that are built into the current projection. Next slide, please. Okay, we've built into the FY21 and FY22 budget the preliminary expectations of the MOE eligibility redeterminations and traditional Medicaid enrollments, of course, workforce participation. We had already built in the high fidelity wraparound last quarter, so that has not changed, but that is a projection, so that the projection could change once we get some actual experience. The annual cost of administering the COVID vaccines was already built in, but at 100% FMAP, so that doesn't impact the general fund. The following are new to this quarter. So we've built in the affordability fund appropriation to adjust the tax, as I just mentioned, extending the postpartum Medicaid from 60 days to 12 months, starting in April of next year, and extending the MOE. What we have not built into this projection is the Kevin S. Intensive Case Management Services for CYFD treatment foster care. We have not built in any potential cost containment, and we also have not built in yet the maternal child health related rate changes. So at this point, I'm going to turn it over to Nicole to provide a little more detail, and when she's ready, we can move on to the next slide.
Thanks, Lisa. So yeah, I just wanted to give, sorry, I'm getting feedback. Just wanted to give a little bit more detail here. I think Elisa covered most of this, and we've talked to you all about some of the work here already. You know, we are still technically, as Elisa said, projecting a significant shortfall. So we know that the state is seeing a better revenue picture, and so we're hopeful that that shortfall will be able to be resolved. But in the meantime, we're still trying to be pretty conservative about any sort of you know, changes to the program or growth in the program beyond what we're already experiencing. So we have put in place into the budget kind of things that we know are costs and that are expansions, but that are likely either required by litigation, which does not negate the fact that we also want to do them as a state, but it is certainly an external driver that means that we know we need to include them in the budget. Obviously, costs for responding to the public health emergency, responding to legislation that was put in place around the affordability fund. And then one of the most significant places, obviously, for growth in costs, well, the two largest drivers will end up being in our 23 budget, postpartum, and in our 22 budget, the MOE roll-off. These both seem like very important things for us to do for this population in our state here. And so we are proposing, as I said previously, to the legislature that we do move forward with taking advantage of this opportunity presented in ARPA around postpartum, and then that we also take full advantage of the amount of time that we've been allotted by our federal partners to roll folks off of the public health emergency essentially related coverage. So those are kind of the largest expansions that you will see in our dollars in the next 2 years. However, there are a few other things that we are looking to address. And so Elisa mentioned the intensive case management is not yet built in, but it is also part of the settlement agreement, and therefore will be required for us to build that in. Cost containment, as I said, a better revenue picture than I think most were imagining. And so hopeful that we still will not need to engage in that cost containment. And then finally, some maternal child health related changes. There is a lot of opportunity for us right now as we look at this extension of postpartum to kind of look at maternal child health care overall. Again, you all know that we cover now 58% of kids in the state of New Mexico and 71 to 72% of births, which are just unbelievable numbers. And I think really call upon us to look at the benefits that we're providing under each of those categories and make sure that they're appropriate, comprehensive, that the rates that we're providing for the services that are most needed in those areas are also adequate. And so throughout 2020, folks still continued to come to us, although with a lot of respect and understanding for the fact that we probably couldn't make changes at that time, given the budget picture, but did call out to us where there were a couple of really significant issues with rates or codes that we were not currently covering or were inadequately reimbursing. And so we intend to try to address those as well here with the legislature and the governor's office as we head into finalizing our 23 budget. So a couple of those include some things where it seems like we are not aligned with standard of care. So on the maternal child health side, for example, there are a number of screenings for pregnant moms that are not appropriately covered under the program currently that we want to address. And there's also a couple of newborn screenings that aren't adequately covered either that we're planning to address in those changes. So we will share those with you all and make sure that you see what we're planning to do there, but really are looking at maternal child health across the board, from family planning services and continued efforts around long-acting reversible contraceptives to taking care of moms when they're pregnant, looking at expanding home visiting and a couple of other efforts. And then once they have the baby, now also looking at those screenings for new babies. And then as they head into kind of those early years of development, making sure that we are working with our partners at PED to expand services in the schools. And so really kind of looking at this continuum and making sure that we're doing as best as we can as a program for a really vulnerable population and highly covered population by Medicaid in New Mexico. So we'll keep you all apprised of those, but that's what that line means there at the bottom. There is a chat. Pleased to see high fidelity wraparound included and the development as such a critical component for youth under Kevin S. However, why isn't intensive case management built in even though it's recognized? Oh, very fair question, Gary. We have just not costed it out yet. There are many things going on, and unfortunately we've had, or fortunately, a lot of great team members getting recruited out into other agencies and getting some advancement opportunities. And so happy for them, but means we've got a shrinking financial department that is working to do not only this work, but try to bring new folks on as well. So we're in the process of determining how we're going to provide that benefit and what it's going to look like and cost. So it will be built in, just in the process. So not to worry, it will make its way in there before we get to session.
Could I ask a question real quick?
Sure.
I think it's an important point. The extension of the postpartum Medicaid from 60 days to 12 months. Am I correct in understanding that the reason you're going to have to go to the legislature on this one is because the Medicaid match is not necessarily what the regular program match is for that extension? Is that correct?
Sure. So can we advance the slides and we'll talk about the cost associated with postpartum, and that will help answer the question. So unlike some of the other provisions in ARPA, where they are giving us additional federal dollars to pursue new initiatives, that is not what this provision does. the provision in ARPA around postpartum essentially makes it so that states no longer have to go through a waiver process to allow for this extension, but allows us to just go through the normal state plan amendment process, which is far less burdensome for us as a state and requires a lot less steps around things like implementation and evaluation plans, budget neutrality exercises, a whole lot of work that goes into those 1115 waiver submissions. So this allows us to have fewer or less burden in implementing this. However, we don't get any additional money from the feds in pursuing this. And so what the result is for us as a program is additional member months, essentially, of women who would only have had those 60 days of coverage, but will instead end up with the 12 months. There are about 27,000, I believe, women who are in our pregnancy-related categories annually. The vast majority of those, I believe about 22,000, I'm giving you ballpark numbers here, but about 22,000 of them will end up falling into an existing category, and so won't really increase our cost necessarily as a state. However, there are about 5,000 of them who would have fallen off after the 60 days and would not be eligible for ongoing Medicaid coverage. And so it's covering those 5,000 women for the remainder of the year that will generate about 14.4 million in general fund increase. In part, another part of that 14 million is that we will also need to change our pregnancy-related category instead of being a partial benefit to a full benefit category, which has some additional costs associated with it as well, and is a requirement of the statute in implementing this extension. So it is, to answer your question in a very short form, Mr. Chair, it is necessary for us to go to the legislature because this is essentially us asking for an additional $14.4 million in state general fund to go towards our program administration.
Well, thank you for that explanation. That's, I understand it. And it's really the 5,000 who would have fallen off of the rolls that we're going to have to be concerned about covering their continued costs, correct?
Yes, it would, you know, I think there's a maternal, I'm probably going to get the name of this commission wrong, and I'm very sorry. So for folks who are more familiar, Maternal Morbidity Council, I think, I'm again getting that wrong. But you know, there's a significant number, I think, national data demonstrating that there are preventable, a significant number of preventable deaths associated with pregnancy that happen just after 60 days or within that 12-month period. There's also a large number of, you know, other physical and behavioral health related needs beyond 60 days that these women may not have access to coverage for, that we know are really critical for not only the health of the mother, but for the health of the family overall. And know that you're doing some really important work there too in rural areas in particular, Mr. Chair. So I think that this coverage will really help those women continue to have access to services that they'll need just shortly thereafter birth. Don't know if I answered your question. I'm sorry. I was reading this. Full disclosure, was reading the next comment in the chat and making sure I was answering that as well.
Well, let me say that it's I think you did provide the information, and I want to commend the department for investing money in one of the areas where I think it's most beneficial to invest these kinds of resources. You know, so I think we will benefit as a state in terms of health status as a result of that. Thank you.
Thank you. Yep. Couldn't agree more. I think this is really important and a great opportunity for us. And should say there seems to be broad support in the legislature and the governor's office as well, although we will be sharing this number more broadly for the first time this today and also in the next 2 weeks as we work through budget presentations. And so I'm sure there will be a lot of questions about it as we move forward. All right, Elisa, it took longer there than I intended, but I think we're still on track. Anything else that you wanted to add in this section?
No, Nicole, I think you pretty much covered it.
Okay. Okay, I see, Sarisha, your question in the chat. I'm going to save it for a little bit later in the presentation, and but we'll make sure to get you a response. Okay, I think
Go to the
yes.
next agenda item, rather
Yes.
the next agenda item, right, which is the PHE timeline. Or did you cover that already?
I think we're gonna go to the supports waiver next, and then we'll go back to the public health emergency. So,
Right.
thank you. So there were a couple of lines that you all saw in the budget where we wanted to provide you some additional information. So Megan is gonna speak to the supports waiver.
Good afternoon again. If we could move to the next slide, and then again, thank you. Just do kind of a real high-level overview of what's been going on with supports waiver. We had submitted it to CMS early in 2020 and received approval, and it was effective July 1st, 2020 for a 5-year waiver cycle. There's still the $10,000 annual individual budget, and they have 2 service delivery modules, which is participant directed and agency based. And then the case management is typically performed through the title of a community supports coordinator. If we can go to the next slide, we're going to go over the services. So here's just a list of services that have been approved with the supports waiver. We have the customized community supports, individual and group, the employment supports, personal care, assistive technology, behavior support consultation, environmental and vehicle modifications, non-medical transportation, and respite. If we go to the next slide, we'll give you kind of an overview of what's been going on with the enrollment. So in August of 2020, DOH sent out 1,000 offer letters. And we had a couple pick up on, by the end of 2020, we had under 100 that had engaged in services. In January, Department of Health sent out another 500 letters, and then again in February, another 500 letters. You can see here that we have 4 categories. We have a large percentage of them actually not responding. We have a smaller percentage that are refusing, and I'll get into some of the reasons for that in a minute. And then we have the number of persons in service. That's the green line there. And as of at the end of July, we had 112 in service. And at the end of July, we had 272 that had accepted. And because the budget is $10,000 over the year, they have time to spend that money, and it doesn't need to be the moment that they have accepted. Some of the reasons people, this is the information that DOH is kind of monitoring. But some of the reasons for refusal is they're waiting for allocation to the comprehensive developmental disability waiver or the MEVIA waiver. So that tells both DOH and HSD that we need to really kind of provide some focus, training, and education to people that they're not being removed from the process to get to the ultimate waiver, but rather utilizing services in the interim. I'm going to pause for a moment because I think someone is off mute. So if everybody could just check to see if they have their phones or computers muted. Thanks. And then a good portion of the refusals were people had already been receiving services through the self-directed community benefit on the 1115 side. So if we could move on to the next slide, we're going to talk about some supports waiver engagement efforts. Next slide, please. So we have a couple of targeted mailings that we've really been working on with DOH. When back in August, we sent about 620 direct letters to people who were enrolled in the MCO. I apologize. I do think someone's on unmuted. If you could mute, that'd be great. Or if someone can mute them. Thank you. So we sent 620 letters in August of 2020, and then we sent another 660 some letters in November. We mailed to MCO enrolled individuals who received the supports waive offer. And what we did was we put kind of an overview of the supports waiver services in the budget. We did a comparison table for community benefits and then support waiver services. And we provided some MCO care coordination contact information, as well as HSD and DOH staff contact information. We'll continue to do those targeted mailings when the offerings go out with from DOH. But the intention is basically just to give an opportunity for the individuals to understand the benefits that they were potentially receiving in comparison to the supports waiver services. We did have a program coordinator join the team at the end of May 2021. A little difficult to hire some people during the pandemic intense months, but we did get someone on, and we really want to work with them to focus on specifically addressing the efforts related to the waitlist and support waiver offers. This particular person is going to collaborate with the MCOs to engage members and the ones who have not responded to the offers. And they'll be developing additional engagement and educational materials so that we can ensure that we're giving the members the most information, the most accurate information. We're also going to continue to work with the MCOs. So there's going to be a deliverable sent out in early August with the list of individuals who have not responded to the supports waiver offer, and then really get the care coordinators to engage, to perform outreach and provide information on the supports waiver and the differences between community benefits. So as I said before, we'll continue providing mailings and education to members and waitlist participants. And then the ARPA. So DOH and HSD has been working in collaboration on some of the ARPA proposed spending plan. And what some of the ideas that they were kind of working on was workforce to contract with statewide needs assessment and home and community-based service provider capacity study. They also would like to create infrastructure for corporate EORs similar to the corporate guardianship. And then they were looking, hoping to do some outreach and education campaign, upgrading their critical incident management reporting systems, implementing no wrong door, such as consolidating a toll-free phone line, and doing public-facing central registry. So those are just some of the ideas that we put forth to CMS to see if we can get approval for that. And if we go to the next slide, I'm going to check really quick the chat because I'm not paying attention to that.
You're good on the chat, Megan. It's another topic.
Okay, thanks. So what I did was, of course, you can't really read this. It's one of those magical slides, but I really just kind of wanted to give you an idea. This is the table that I was talking about. It's the comparison grid between the community benefits and the supports waiver, and then care coordination activities aligned with that. So this is the actual separate sheet that goes with each letter. When they have an offer letter sent, then we send this this informational and educational material packet as well. So just kind of want to give you guys a picture of what that looked like. And if we go to the last slide there, thanks. So Victoria Herrera is the program manager for supports waiver at HSD MAD, and Jennifer Roth is the DOH program manager, and their contact information is on the slide. So if anybody needs to reach out or has any further questions, of course, you guys can always reach out to me as well. So I think if we go to the next slide, that is the PHE.
Thanks, Megan. Thanks for the update. Any questions there?
Oh, I think we're ready for the next agenda item, Nicole.
Great. All right. This one is back to me. Lorelei, our other deputy who would be covering this for you all, is taking much needed vacation this week, which we are encouraging all of our staff at this point. So I will go ahead and walk y'all through the PHE work that they've been doing, but and if I'm not able to answer any specific questions, we'll get back to you all. I'm sorry this slide is really text heavy, but we'll push through here and highlight the important parts for you. So, you know, the header on the slide is obviously that the Medicaid pandemic wind down is a bigger challenge, meaning for us as the state agency operating than the pandemic itself was. You know, I think that means both for us and more importantly for ISD. The team worked incredibly hard at the beginning. You all saw all of that work around waiver submission, et cetera, changes in rates, lots of engagement with federal partners to adjust, and then subsequently our MCO partners, providers, and members, and obviously the challenge of the pandemic itself. Nothing like just an unbelievable burden for folks, of course. What we're talking about here is the actual workforce requirements to now roll all of these folks off of the Medicaid program. And to be honest, it is one of those things that keeps me up at night. It is a huge number of people, and we are, of course, going to be heavily reliant on our systems and making sure that we know who the right people are to terminate coverage for. Right now, and that's this first box here, the federal government has signaled that they believe, they sent this out to the governors early when the Biden administration came on, that the public health emergency declaration, which is what allows folks to stay on Medicaid currently, that declaration, they believed at the time, would come to an end at the end of this calendar year. Obviously, things have begun to change. I'm sure many of you saw maps this morning when you're reading the paper or skimming your news on your device. And unfortunately, most of the country now is red and high or significant caseloads. So given that we're in August and certainly nearing a peak of some sort, not sure if that date will still hold. But that is the guidance that we have as of now, and so the way that we are planning at this time. The number of people that we have extended coverage for is about 130,000 individuals. We believe that about 60,000 of those, 50 to 60,000 of them, are no longer eligible for Medicaid. So you all have heard us talk about that 50 to 60 number quite a bit. But the reason this is so burdensome and scary for us as an agency, for us and our partners at ISD, is because the renewal notices and the work to determine who is eligible and not includes all 130,000 of those people. Not to mention the folks who are also normally up for renewal during each of the months in which we'll be conducting this roll-off. So that increase in workload for the ISD workers is pretty unbelievable. And so, it's basically the work that we do over a 12-month period being crammed into what was initially an attempt to look at a 3-month period, and now looking at a 6-month period on top of their normal workload. That's not just the ISD folks in the field offices, but also our call centers. And you know that means that kind of workload for them means a lot of frustration for members if wait times are long, if there's confusion about their information being updated and correct, etc. So we're going to talk about the communication plan here in a minute and our attempts to try to mitigate all of that as we move ahead. But just talking through that, hoping that folks are realizing why we are pushing so much to take full advantage of the 6-month period that the feds are allowing for that roll-off at this time. So assumption number 1 in the box here, like I said, is that the PHE would terminate at the end of the calendar year. Next, and this was a question in the chat, we've had to determine what the roll-off plan will look like. So of those 60,000 people, folks are parts, of course, of all different kinds of COEs and categories of eligibility. And right, what we've been going through in partnership with ISD is figuring out the order in which we want to try to roll folks off. So there are populations, for example, who have aged out of their category of coverage. So they were a child, turned 18, no longer part of that population. And so they won't actually have their coverage terminated, but they'll need to be moved into another category potentially. There are other categories like that, but there are other categories that are a little bit more sensitive, where we're worried about transitions of care, worried about folks making sure that they get onto another source of coverage because they have ongoing healthcare needs. And so trying to figure out how to stagger those populations so that we have an effective way to try to have our ISD folks work through these cases. We're still working on finalizing that approach and also have been working to get some additional guidance from our federal partners about their expectations there. As soon as we have the final roll-off approach, we'll share that with you all as well, because you all will also be really critical partners with us in the communication about this effort as we get closer here. So that hybrid model for roll-off is what we chose. So essentially we'll be considering those specific populations and doing a staggered roll-off so that we avoid a cliff effect. Pre-termination activities are going to begin prior to the end of the year. You'll see the timeline here in a minute, but automated renewal activities on the MOE population will be reinitiated in October. So that is when messaging will begin going out from HSD to this population. And then again, you'll see how we're trying to work with our partners on staggering all of the communication as we get closer and closer to December and January, when folks will actually have that coverage end. So again, we just talked about this, so I'm not going to reiterate, but the 90 to 120 day time frame for roll-off. And again, we are targeting that 6-month approach. You can move to the next slide, please. Okay, so this gives you all a sense of what's ahead. We have been working on the waiver terminations. So beyond dealing with the kind of roll off of folks and making sure that we're doing that appropriately, there's also a lot of waiver activity. We have to undo all of the work that we did in state plan amendments, supplements, LODs, that all has to be reversed when the declaration comes to an end. Additionally, there was a lot of system work that went in place to, for example, suspend terminations of folks who are no longer eligible. So we have to undo that system work and turn that back around. We also had put in place, a category of eligibility for the uninsured population so that they could have access to COVID testing and treatment. That will have to be undone as well, as that category will no longer exist once the declaration comes to an end. Additionally, you can see the next row here, communication planning has been going on not only within HSD, but with our partners at at BULNM, the Health Insurance Exchange, and also with our MCO partners who have been great in working with us on what this communication will look like. And we'll also be working with all of the other state agencies here that have an opportunity to work with us on this communication in the very near future to help make sure that they understand what's happening, specifically for folks like CYFD, where there may be children that we need to be making sure are handled appropriately. So then beginning in September is when actual communication will start being developed, will be finalized, I should say. And then in October, as I said in the previous slide, we'll see that communication start to go out to members. System implementation beginning now and in September primarily. That work will be really full steam ahead. And then when we get to January, you can see here when the roll-off will actually happen. And the system will start triggering those terminations and account transfers of those clients over to the state-based exchange where they may be potentially eligible for coverage. And then finally, financial reporting, an ongoing effort. All right, now we're going to head into the communication strategy section. I'm going to pause. I think there's, oh, okay, thank you, Secretary. And we're going to move into the planning and communications section here. Let's go ahead and move forward. Okay, so these teams have been meeting, the three that I mentioned, along with a number of other folks, but three primary teams have been meeting to work on strategies. So what we're trying to do, we're worried that members are going to get bombarded with information at this point. And so what we are trying to do is streamline those efforts and say, okay, beginning in October, HSD starts communicating with these members. We then share the list of those members with our MCO partners that we believe are going to be terminated. The MCOs can start doing direct calls, mailing, etc. with that population, talk to them to make sure that their information is updated, or talk to them about continuity of care and moving into a plan on the state-based exchange. So if we're October timeframe, you've got, early October, you've got MCOs talking to members in late October, and then BULNM open enrollment begins November 15th. So they've got the first 2 weeks of November to hit these same members. We'll be sharing the lists with them as well. And they will go to those members and talk to them about getting enrolled with a plan there. And then as we get through open enrollment and into January when they will actually see their coverage terminate, again, we will be heavily working with the BULNM folks to work on their receipt of the account transfers, make sure that's successful. This is their first year as a state-based exchange, just kind of compounding what will happen here and making things a little bit more difficult. But also, I think we've got a really good partnership in place there, so hopeful that things will go smoothly. But again, heavy reliance on systems always makes me nervous. And then, of course, coordination with the MCOs, and a number of them, of course, have plans on the exchange and making sure that folks understand what options are available to them there, especially with the new coverage provisions under ARPA, which actually mean that there are zero premiums really for folks up to about 150% of the federal poverty level. So while they may not have Medicaid coverage, they could still move over to the exchange and not have a premium up to that 150%, I believe. So we'll be working on that messaging. And for us, the heavy message at the beginning is going to be, please, please, please update their information and make sure what we have is correct. This MOE has been going on for a long time. People have stopped kind of responding to mailings from us, and we need to get them re-engaged. So that leads us to the next slide. And the teams have all agreed to shared messaging here, which is back on track. You can see that kind of shared logo down there that all of the impacted stakeholders are going to utilize. Everybody's agreed to try to work on shared messaging that I know is actually, I think, close to being finalized now. And that way we try to keep from confusing members with what is a fairly complicated kind of situation that they're not used to experiencing. Why has their coverage been extended for so long and is just now being terminated? Especially if we are still experiencing a high number of cases at the time that the federal government feels compelled to end that declaration. Folks will wonder why we're ending their coverage, you know, when things still look the way they do potentially. So a lot to work through there. You can see listed on the right all the modes of communication that we intend to use. Again, really trying to work hard to streamline that and avoid oversaturation so that folks actually read those messages and engage with us. And we are more than happy to receive any suggestions from you all about how we can improve communication strategies and/or things that we may be missing in some of our efforts here. And we'll be providing you a more in-depth update on the communication plan at the next meeting, because we will be well within those activities and be happy to have any additional info from you all at the time. Okay, let's move forward. You all heard me talk through this, but essentially the buckets of time in which each of the stakeholders is going to plan to engage with these members, and this is just a visual representation of that when each entity will be engaging at which time. Okay, I think that's it for the wind down, and so I'm about to turn it over to Mr. Estrada. But before I do, are there any other questions about the end of the PHE? Okay, just lots of work ahead, lots of concern about the number of people and our call centers and staff's ability to process them timely and make sure that folks have a smooth experience. So we'll keep you posted and are doing our best to get all of those pieces sorted out. All right, Ebuka is going to talk to you all about our previously EMSA program. There was some great legislation proposed last session that didn't quite make it through, and we committed to working on it, and Ebuka has been doing that, and I am happy to turn it over to him to talk you through the details.
All right, thank you, Nicole. If we can advance to the next slide. And so as Nicole mentioned, we are changing the name of the EMSA program. Most of you probably know that Medicaid provides emergency services to non-citizens who would qualify for full Medicaid, but for their immigration status. And we do that through what is known as EMSA, or Emergency Medical Services for Aliens, aligning with that legislation that was presented during the 2021 New Mexico legislative session, along with some action at the federal level. We're going to amend the NMAC to change the name of EMSA to Emergency Medical Services for Non-Citizens. We're also going through the administrative code as well as our IT systems and paper applications to remove all references to the term alien and change those to non-citizen. We expect all of those changes to be effective on January 1st of 2022. And so that's the brief update. If anyone has any questions regarding the EMSA rebranding.
This is Sharon. I just want to say thank you for that. I applaud you for making that change. I just applaud you that you all are always member-centered, and that makes me very happy. Thank you. I thank you for that.
I'd like to echo that sentiment. I think we need to be very sensitive to terminology that at one time seemed to make sense, but certainly doesn't make sense any longer. And thank you very much.
Thanks. Thank you all. Ebuka, can I make your announcement here?
Sure, go ahead.
Okay. Really put you on the spot there, because if you said no, it would have been awkward, but so apologies. But I think a lot of you are very familiar with Ebuko, and we have been so thrilled to have him as part of our team. But he has has been recruited, stolen by our partners at CMS, and will be joining the Federal Office of Legislation there. Which is honestly just such an awesome fit for him. I think he's going to do such great work there, and we are very, very excited for him, although sad to lose him. So Ebuko, we wish you all the best. I think this is your last MAC meeting, and have been so happy to have you as part of the team doing great work like this in particular.
Ebuko, you and I go back a long, long way, and I hate to say it, but CMS's gain is our loss. But we want to wish you the very best. I'm sure you'll be a success there, just as you've been in every role that you've played here in the New Mexico Medicaid program. So we'll look to you as a resource.
That's right. Don't think that we'll let you out of additional work. We'll just be sending you a different kind.
Okay.
But thanks, Ebuko, very much for making this change and pushing it through. There's a lot of rule changes, and to the team who worked on it as well. I think it's really important, and I'm happy that we were able to move it forward. All right, let's go ahead to the next item.
Nicole, it's item number 15, I believe it is.
Yes, thank you. And this is just a very brief update on home and community-based services, our spend plan, and the American Rescue Act dollars. So we can go ahead and move forward, please. So we just want to remind this group, we talked you all through in a special session. I know not all were able to attend, but we talked you all through what our proposed spending plan is for those additional dollars that are coming to us to enhance, expand, or grow home and community-based services coming out of ARPA. We submitted that proposal to CMS on July 12th. And on July 17th, we posted that same document for public comment. Apologies that it came after, but we held a number of public forums to try to make sure that folks had an opportunity for input, and also directly engage stakeholders to get that input and included it. But once the plan was finalized, we did still want an opportunity for public comment, given that we have 3 years to spend the money, and some time to update that plan as well. So if you have any comments, please get them submitted by August 18th, and then we will be reviewing that feedback to incorporate it into the quarterly submission that we will send to CMS for our next kind of round of funding and or answers to what are likely to be a number of questions from them about the initial proposal as well. All right, let's go ahead and move to the next item, which I believe is public comment. So Mr. Chair, I'll turn back to you.
Thank you, Nicole. I don't know if anyone has, I've been checking the chat box, and I've not seen any specific requests for public comment. Do we have any public comment, first of all, from members of the Medicaid Advisory Committee? Anyone wish to comment on any element that we've discussed or any other item that's pertinent to the Medicaid program? If not, then we will open it up to any other members of the public. I'll entertain any request for anyone who wishes to comment on the program. Well, seeing that there is none, then I think we can go on then to the next item on the agenda, which is item number 17, which is adjournment. I will entertain a motion to adjourn. Anyone wish to venture?
Hello,
Okay, who's this?
this is Sharon.
Sharon, thank you, Sharon Huerta. She is so moved. Any, do I have a second to that motion to adjourn?
Yes, this is Rick.
Yes, okay, thank you, Rick. Before we adjourn, I want to thank everyone for all of your time, attention, and for the wonderful job that the Human Services Department staff has done in providing us with, again, a tremendous amount of information, and they do a wonderful job. I just have to commend you for the detail and the information that we receive. I think we are the best informed advisory committee in state government, and I want to thank you very much for that, Nicole and members of your staff. So,
Thank you.
all those in favor of the motion to adjourn, please signify by saying aye.
Hi.
Anyone voting no to adjourn? Okay, any abstentions? Okay, hearing none, then we are officially adjourned a little early. So thank you all for your time and efforts, and we are adjourned. Thank you.
Thank you all. Take care.